groups, you'd already have the lectures, right, where we talked about this, and then you'd break up into small groups and break down the case. This time you're going a little more, active learning style, if you will, and you're going to jump right into the case, break into some groups, talk about the case, and use the slides to see what you guys can come up with. Then Mike and I will have a discussion with you guys, and we'll kind of put some, we're going to pick groups and put you guys, have different groups tell us what they would do. Then next week, Monday and Tuesday, we're going to have the lectures, right? So it's a little, as long as you get all the material. I don't know if it's important, the sequencing. I guess ideally you would have the lecture first, ideally. I don't even know if that's ever been proven. But we'll have kind of the discussion first, raise some questions at the least. Right? Then when we do the lecture on Monday and Tuesday, you guys will be able to reflect back on the case. So we're just doing it in kind of reverse order, just to try, like I said, try to maintain some semblance of order despite all the snow days. And then I saw an email from your class president to some other professors. Apparently you guys have 3 exams. Mm-hmm. So that's George.
Sucky.
What's that?
Thursday,
George. What day are your
Thursday and Friday.
Thursday, Friday?
Thursday's med chem and yours, and then Friday is pharmacology.
It sucks.
We were prepared to just deal with it,
but
but
and then we moved it.
and then it wasn't.
What's that?
It was fine and then it wasn't.
Yeah,
Did anything else get moved, or is it just therapeutics?
just yours.
So then what would it be? Tuesday?
It was Tuesday, and then those
Thursday,
those
Friday.
two are always together now because of the content.
We can go back to the Tuesday exam.
But then it's
What's that? So you have them Wednesday, Thursday, Friday?
That's better.
Really?
Oh, 2 in 1 day kills me.
Yeah.
So what are the odds that this is going on Monday that we would be back?
Well, the odds that tomorrow the
Tomorrow,
other
yes.
seminar is probably not going to get to go is high. That's a very high likelihood. But the one on Monday is 50-50. The one on Monday is still 50-50, according to the weather people or whatever. I had a meeting with the provost just before this, and if anybody would know at the university, you'd hope he would know. And he said it's clearly 50-50 for Monday. Tomorrow, it's very likely that there'll be some problems. But that probably wouldn't impact till later in the day. Assuming that doesn't happen, the other last option would be to have the exam maybe the following Monday.
Yes.
If I can, and that's probably where we're leaning.
Yes, that would be fantastic.
Yeah, that would be perfect.
It really would.
Yeah, see, I was joking. What's that? Yeah, that's probably where we're leaning, but I have to talk to, I've been at Biddeford all morning, so I haven't had a chance to talk to Sherwood yet to see how much that would throw her schedule, right? Because there's a lot of, cogs in the wheel. So it might be a case where, you would have to do one of her lectures on your own, and in order to make it happen or something. But that's what I'm leaning towards, because this is just been the craziest. This is literally the most unique semester I've been part of yet, just the way everything got started and snow and I'd rather you guys have good feelings leaving my module than frustration. So that's the plan. So in the meantime, though, I want you guys to, I don't designate groups, never, you guys break up into some smaller groups, people you feel comfortable working with, kind of work on the case a little bit, look at the slides. We'll reconvene in a little while, I'll kind of just get a gauge on it, and then kind of put you guys on the spot to see if you guys came up with anything good. And then, of course, we'll have the lectures next week, and then you can reflect back on this. Not ideal, but we're kind of stuck with that. And again, I don't even, if tomorrow seminar gets canceled, I wish I would have thought about it. I would have had everyone come today, is what I would have done, but I didn't, I'm not a weatherman, so I didn't really know that was going to be a possibility. And poor Mike on his appy, he hasn't seen me all week. He's probably heartbroken. Although, how many times did I email yesterday? 30?
13.
That's it? That's it?
He had that answer ready, though.
I know, he was gonna give it to me anyways. Do you have to email me so many times on a snow day? All right, plan's good. I'll talk to Sherwood and see if that's just gonna destroy her flow. If it's gonna really throw her whole game plan off, then we probably won't be able to do that. If she's like, fine, it's not ideal, but I can manage, then we will do that. George Allen, the coordinator, he agrees with me that would be a plan. So it looks as if that's good, but you just can't, just destroy someone else's plan either, right? So let me talk to her.
What format is your exam in? Like, is it essays? Is it multiple choice? Is it a mix of all
It's
kinds
all
of stuff?
It's all ExamSoft based. The whole college is moving towards
Right.
ExamSoft for like accreditation purposes. We can do a lot more with assessment. So everyone's moving towards that. Most of my questions tend to either be multiple choice, fill in the blank, matching, pretty much anything that you can do in an exam-based format. I stay away from the essay because what I tend to find, at least in psychopharm going first, is students give really good answers and then they end up getting really tangential, and then it's like, well, how do I grade that? The right answer's in there, but then they destroyed it later. And I just can't, you know what I mean? You guys know what I'm saying. So I try to avoid that. It's not a good topic. Psychopharm, your very first topic's not good for essay. So
So same with your quizzes too.
yeah, quizzes. And the quizzes were going to happen today, but obviously we got bumped. So I want you to see some questions before the exam. So as it stands now, the quiz would occur, Monday or Tuesday, depending. I'm reluctant to say Monday now that everyone's talking. Maybe I should just set it on Tuesday. I don't know what to do. It keeps being a moving target with the weather. But it would be you would see a quiz prior to the exam, so you could get a flavor for the questions because they wouldn't be dramatically different. Only difference would be quizzes are set up very modular. Exams, you might have 3 questions that kind of relate back to one case. So, the quiz questions are just very more of the fundamentals, I guess, but not that different. Mike, they're not that different, are they? My quiz questions versus my exam questions? If you've seen a couple of my quiz questions, you probably at least know what to expect. What you say?
I only have one quiz with you, right? You have one quiz with two.
With you guys, it's typically at the most quizzes I could ever have is 3, and then with the weather, it's usually been less than 3. So I don't know, 1, 2. Yeah, I told you this is 5 years in a row of snow days, right? Multiple snow days, not just one, multiple. That's why I want to get out of this. I don't want to be first anymore. I don't want to. All right. Well, it's kind of fun too, though, right? Because at least it's not boring. It's kind of like, oh, what's going to happen today? Oh, no school. Right? So that's kind of fun, even for me. All right, we good?
One more question. On your multiple choice, like you have said, therapeutics, a lot of times it's decision making.
Yes.
Are your answers pretty obvious? Like if you've studied and you know what you're doing, are they obvious? Because
So I write 3 kinds of exam questions, basically. And because we're using ExamSoft, it really is forcing a lot of people into doing it like this. So I have like kind of your confidence booster questions. If you were at all paying attention, you should do well in that question. Then there's the kind of question in the middle where if you're reading the notes, you're paying attention, requires a little bit more thought. Bell curve, most of the class is going to do well. Then there's, I always throw in a handful of questions that are really like, who's really paying attention. But the really paying attention and the confidence boosters are kind of the less questions. But in a confidence booster, or I'm sorry, not in a confidence booster, in a question designed to separate people out into who's paying attention, who's really paying attention, there could be things like, you should have picked up on the fact, and I hate giving away such important keys in one conference and not another conference, but like bupropion. Did you ever hear me link bupropion to the treatment of anxiety? Once.
no.
No, you didn't, right? So I would have a question where you can accumulate points, but if you answer bupropion, that's a deal breaker, right? That you don't. I can no longer tell that you had any idea what was going on if you put bupropion. So I try to set them up where, if you went up and you said these are 2 really good options, but you missed a 3rd really good option, okay, you get some partial credit. You give me 2 really good options and then you just derail with bupropion for anxiety, you don't get anything. So I try to set up like how it would be in real life.
So your multiple choice questions are multiple answer.
Sometimes.
Will we know ahead of time? Will you say in the question, choose all
Do you hear
correct
that, Mike?
answers?
Did you hear that? You thought I was just being nitpicky. Ask your question again.
Does
He's
he
been writing questions with me, so
does he put, if more than one answer applies in the question, choose all that apply, or do you just have to know?
Yeah, he's specified. You do those though.
Okay.
try to.
Yeah, it's
I try to. But that's easier said than done because you write a question, you think you specified, you didn't, or or you specify all that can apply, but there's only one answer and everyone freaks out.
Yeah.
Right? But more than one answer may apply. It may. It wasn't designed to trick you, it's just because you get so used to trying to specify everything, you over-specify. And then you have students saying, well, you said may have more. Well, I said, it's
May.
true, may have more. I would, So, yes, I try to specify and I don't try to be tricky, but I think people, it's like I always say this, you get what you ask for. People ask me to specify, but that can work the other way too. Like where students overthink exams.
Will you clarify during the exam if somebody has a question? Are you here to clarify?
Yes.
I am that person that will raise my hand and ask you to clarify
I think
something.
I can honestly say at the end, despite, everyone responds to different teaching styles, but I definitely am a fair about it, So if something doesn't make sense and 3 people ask me, I will tell everyone, okay, listen, 3 people have had trouble with this question, something's going on, this is what I meant.
Okay.
Yeah. It's not meant to trick you. All right,
Okay, thank you.
good questions. Why don't you introduce the case?
Go ahead,
Your
Sarah.
group.
Oh,
So you just stand.
I
stand
do.
up.
Yeah, hold on.
Stand up.
seriously?
Yeah. This is a case study. This is supposed to be putting some stuff on you guys.
Yeah, go right up front. Use the microphone. Grab
What
hold.
one is this?
So introduce the case and tell us what's going on, and then we'll put some pressure on other people to say what are you going to do about it.
Okay. So we have a gentleman, CAB, 40-year-old male coming into the hospital with a 20-year history of alcohol dependence, 15-year history of benzo abuse. Do you want me to just read it?
If you just want to read, chief complaint. If you just, as long as everyone's on the same page.
Okay.
You have to read every word. Just get everybody. To the same page.
So basically, he was sober for 18 months, and he had some job security stressors, and thought that he could just have a couple of beers to relax and fall asleep. He was having trouble with sleep. He ended up, once he had a couple of beers, completely binge drinking. He had a 12-pack within the first few hours. So, let's see.
So then in that, there's a lapse and a relapse. A lapse is somebody takes a drink because they think they can handle it. A relapse is they think they can handle it and they just boom.
So he had a relapse.
They had a relapse.
So he went from, I don't know where it says stuff. So he went up to, a liter of vodka a day.
Mm-hmm.
And, let's see, so basically it comes in no tobacco use, positive for alcohol, no benzos, his family history of alcohol dependence, no known allergies, Benadryl and NyQuil both for sleep as needed, and he's hypertensive, 154 over 95, tachypneic at 20, tachycardic at 110, and his, temp is normal. His pupils are equal around and reactive to light, horizontal nystagmus, so he's probably still a little drunk. Smell of alcohol and breath, otherwise calm and cooperative. Do you want me to go through labs?
No, that's good.
Okay.
A couple of things I was going to say. Thank
Yeah.
you. Thank you. So I'm going to start right off with the nystagmus, because you were talking about him still being drunk. Does anyone have a theory based on what's mentioned in the notes? And I also posted some supplementary notes, the neuropsych assessment. Did you guys all see that? Which it has some Stephen Stahl stuff in there, it has cranial nerve stuff in there, parts of the brain in there. Does anybody want to guess what's causing the nystagmus? Which group has a good explanation for what's causing them? Come on up.
Oh.
Or just stand up, so you guys
Would
aren't running.
it be the Wernicke's encephalopathy from the nothymine given?
Okay, so the Wernicke encephalopathy definitely can be associated with visual disturbances, so that's one possibility for sure. Even without Wernicke's, because we're going to talk a lot about Wernicke's, that's what, when you guys are asking.
We concluded that, yeah.
So Wernicke's is a full-blown neurological condition that we're going to talk about that's related to thiamine and glucose, right? But without even going that far, what's something, and I'll give you a hint, involving the cranial nerves that could explain his nystagmus. And I won't make anyone come up here, but stand up,
So,
stand up and explain it.
why?
Anybody know?
So,
Anybody? Probably nobody looked at those cranial nerve slides, I'm guessing.
no, we had a snow day.
Hmm?
No, we had a snow day. We didn't do anything.
Yeah. I'll start with which cranial nerve? What? Close. What cranial nerve controls extraocular muscles?
Is it oculomotor?
What?
Is it oculomotor?
There's a group of them, right? Oculomotor,
3, 4, and 5.
right? Try 3, 4, and 5. It's not 3, 4, and 5.
No, 3, 4, 3, 4.
Yeah, I was gonna say, wait a minute.
Oh my god, I can't read from
Yeah, 3, 4, and 5. But my point being that even without having full-blown Wernicke encephalopathy, which is certainly possible in this case, you can have damage to the cranial nerves that control the muscles of the eye.
But you can have nystagmus while being drunk too.
Yeah, but and that goes back to poor muscle coordination, right? Right. Yeah. So it could be poor muscle coordination of the eyes, right? Because when you have poor muscle coordination all over your body, it can impact any muscle, right? Any muscle. So it could be intoxication. There you go, Mike. There's another reason to put intoxication back in. Did you hear that?
No.
Nope. He's honest. Nope. Yeah, so acute intoxication, poor muscle control, Wernicke encephalopathy, cranial nerves, right? Toxicity to the cranial nerves. So there's a lot of different things going on there, and you have to tease it all apart. All right. So what else did you say in the case? Drinking a lot of vodka.
No benzos.
What's that?
No benzos.
No benzos, has some insomnia. All right, what was the first question in the case? I don't have it in front of me, I'm just kind of, what's the first,
Do you agree with the SIWA treatment plan thus far?
yes. So one of the groups explained to me why they do or do not agree with the CEWA treatment plan. Not other than this group, just for a moment. Just for a
Question.
minute. Yeah,
Just for when it says hospital day 1, is that on their admission day or is it the full day after? Because it made it sound like they were admitted and then they were treated on the first day. But was that their course of stay on admission day, like day 1?
well, day one is, so you inherit, and it depends when you inherit the patient
Right.
too, right? If you inherit the patient, let's say 9 a.m., and they go through the ER or the psych ER, and they end up being admitted to your floor for inpatient detox, that would start day 1.
Okay.
That would be day 1. If somebody came in at 11 o'clock
Then I
at
have a
night,
problem.
came in at night, they slept the first night, and then you start, so it kind of depends. And that comes into play a lot of times when I've done studies where you're trying to look at how much medication was given, and say they were admitted at 11:30 at night, and you give them 1 dose. Does that count as day 1 of dosing? So the whole day 1, day 2 thing's never really, it's kind of a little bit arbitrary, but let's assume they came in the morning, and they started that day, they were drinking all night, 7 hours since last drink, so say they drink till 2 in the morning, and they show up at 9 in the morning, something like that. All right. How about this group, since you were looking at me? Who agrees or doesn't agree? Everyone's going to be like, who agrees or doesn't agree with the SIWA from your group? And just stand up. One of you guys volunteer to stand up. Yeah, this guy's got it.
So I got to fail now. Okay.
No.
We don't
So
agree.
far, so good.
No. Since day 1.
Benzos are required to prevent
ER.
the seizures that are going to come with withdrawal. They completely depress the central nervous system. The dosing with whatever the acronym is for that test.
SIWA.
Yeah, greater than 10 falls within what it says in the slides. I think that there are things that could be added, but controlled use of benzodiazepines with respect to his tolerance, if there is still something there, could be useful.
Okay, so you hit the 2 most important. You correctly identified that there's probably more, but you correctly identified at least 2 essential points. SIWA greater than 10 probably means you're going to need some benzo, right? And the primary reason you give benzos is to prevent seizures, right? That's the primary reason. When you think alcohol withdrawal, you should immediately be thinking seizure risk. So yeah, good job. All right, so CIWA, we're going to go with the CIWA. We're going to do benzodiazepines based on CIWA scores above 10. Good job.
Yeah.
What was the next question?
Please identify a potential treatment-related problem.
So there we missed part of the,
The
His-
hospital course.
there's another part of the hospital course in
Yeah.
there. Yeah, give me the other part, the thiamine glucose piece.
Yep, so after 5 hours in observation, he reports feeling anxious and beads a sweater visible. So hospitalization day 2, the patient's blood glucose is low, and his wife reports the patient has not been sufficiently eating or drinking fluids other than alcohol for weeks. Labs are repeated, and the patient is giving 50 mLs of 50% glucose solution given by IV push. Furthermore, the patient's standing CIWA-adjusted benzos are administered, and he is closely monitored. Over the course of the day, the patient rapidly becomes very confused and develops a slow ataxic gait.
Okay, good. CIWA's in place. Now we're looking at this low glucose, right? Alcoholics aren't eating. They're getting most of their calories via alcohol, right? So there's a few clues in the labs that clue you into that. Patient's a little bit dehydrated, right? Their BUN to creatinine ratio is pretty high, so they might be a little dehydrated. They're malnourished because their glucose levels are low. And some of their electrolytes are concentrated, again, because they're dehydrated. So there are clues built into the labs that would make you think that this person's taking in a lot of their calories via alcohol, right? So we're going to give the glucose, but then because your group were, I'm sorry, you're over here with the Wernicke. The Wernicke answer, you don't have Wernicke. Why do you think Wernicke is presenting or being exacerbated? What have we done to exacerbate this possibility of Wernicke? Which is, in Wernicke, right, ataxia, mental confusion, visual disturbances. So what did we do to make that worse? So you didn't administer thiamine at all? Did we give thiamine at all?
Not according to this.
No thiamine at all.
Nope.
All right. So typically in a real life situation, thiamine, people you hope aren't going to forget thiamine altogether, but the problem usually comes in the sequencing, right? All these orders start coming in, and somebody gets glucose, right? Before their thiamine, what have we done?
We've
Wait.
exacerbated.
Let the Wernicke person finish first. Sorry. What have we done? You didn't administer thiamine. You administer glucose, and what do we do? Well, thiamine is a quote, it helps you get glucose into your neurons. All right, at the most in easy speak, right? An oversimplification. Thiamine is necessary to get glucose into the cells. Glucose is your brain's only fuel. If you give a bunch of glucose without giving thiamine, your body doesn't store that much thiamine. I just told you the person's not eating. So what you've done is you've wiped out any available thiamine left, right? Because you don't store much. The glucose level is going to skyrocket, but you're not getting any glucose into the brain because you can't transport it, right? So by wiping out the rest of the thiamine, that's what's, theoretically, you're wiping out what little thiamine is available. Now you can't get any glucose into the brain, even though you just gave a huge bolus, right? You kind of see that the sequence is important here. That's why I'm trying to make sure you have to give thiamine first so that when you give the glucose, you can actually get it into your neurons, in your central nervous system where it's needed, versus the other way around where you gave the glucose, wiped out the remaining thiamine, and then you exacerbated Wernicke. So the sequencing is what I'm trying to get across, right? No?
Well, yeah, that totally makes sense. I'm just wondering, why did they just opt for IV? He's up, he's talking. Why is he not eating?
Why would you opt for IV?
Yeah.
Well, when you get to the thiamine, I don't know if you saw the thiamine notes. There is a whole conflicting literature on how to best give thiamine, right? And you don't absorb that much thiamine if you take it orally. So a lot of times what you'll see is, what do you guys call it, like a banana bag or whatever you want to call it, where you dump everything in. And maybe you didn't need to do that for the glucose because he's up and talking, but you certainly probably needed to do that for the thiamine because you can't absorb that much thiamine at once. So, you know, could you give it?
I just feel like it's a bit extreme
Could
to
be,
do
yeah, could-
anything IV for him because he's.
It could be, but if you look at the British Association Psychopharm guidelines that are in the notes, you'll see that they give 500 milligrams of thiamine. And if they already have somebody who's suspected of it, like the nystagmus, they may even go higher and give it by, give it by injection.
Just across the board.
Yeah, look at, if you, it's in the notes. We're going to talk about it on Monday or Tuesday. But they'll go injection, get thiamine, because you couldn't, I don't think you'd be able to make the argument that even if this person's walking and talking, that you could get enough thiamine into their body orally to handle all the glucose, because you don't absorb that much thiamine. So I don't know if you already suspected nystagmus, I think you'd have it could be a hard sell. And the guidelines would support that. The guidelines would support if you suspect Wernicke, and in this case we do because of the nystagmus, not guaranteed, but it's suspected, you're gonna be more aggressive. That's just what it is. It's a good question, but I think the guidelines support it, yeah. Good question though. What's next? So maybe we participated in Wernicke's, maybe not. Let's assume we cross that hurdle, we cross that bridge. We figure it out, we start loading them with thiamine, and you need, what is your name again?
Sarah.
I want you to look up the bioavailability of oral. How much oral thiamine do you actually get into your body out of a 25 milligram dose? So when anyone has a really good question like that, they have to follow up. Right, Mike? Mike?
Yeah.
If you have a good question, let me know.
You follow up?
She's following up. Remind me to follow up with her later about the thiamine. How much
She'll have an
thiamine?
answer in 5 minutes for you.
Good. All right, so we took care of the thiamine issue. Now we're going to go on to long-term treatment. What could we do? So the benzo piece better be part of your plan per SIWA. We covered that. We now know that how to avoid precipitating Wernicke. Check. What are we going to do for this person long-term? Remember, he has a supportive wife. That comes in. That's important. He has a supportive wife. What are we going to do? What group has been the quietest all day? Actually, since we only have, about 10 minutes, I'll take any and all answers at this point.
Campril 3 times a day dosing is tough and compliance is pretty low, but where he has a supportive wife, she's going to be nagging him to take it 3 times a day and stay on it.
Oh, good answer, but
Oh.
is that hard? Is that too harsh?
No,
Is that
no,
too
it's
harsh?
fine.
I never know.
We
You're
do
always
it
being told
gone.
this. It's like, don't use red ink. Sorry, I was just trying to.
Don't use red ink.
I don't like to use red ink, right?
So, since he's shown that he could abstain from alcohol for a significant period of time in the past, he used naltrexone, and it would increase compliance because it's a long-term injection.
So our first reaction was to go with antabuse because he had nervousness and insomnia, so that kind of takes care, like one of the CNS effects is fatigue, and it's only daily is a typical dose. But then as we read on, naltrexone is first line, so and then it tells you to basically switch to antabuse in the last question. So I think antabuse. Long story short.
All right. So when you guys asked me the question when we were walking around, right? You guys were talking about, well, we wanted to go with the first line agent, which makes sense, right? Naltrexone and acamprosate are first line agents. Nobody's going to dispute that. The thing is, when you're giving recommendations, yes, what you would say in the situation is, well, the first line agents are these. However, this person has insomnia, which seems to be the primary reason they return drinking. Both acamprosate and naltrexone cause significant insomnia and other symptoms. So in this person, first line doesn't apply. And the reason I brought up the adherence is because, in fact, the only reason disulfiram does so poorly is because people stop taking it as soon as they figure out that if they drink, it's going to give them a horrible reaction. So they just stop taking it. Right? So that's a great question. First line doesn't matter here because there are patient-specific factors that are more important. Okay? So patient-specific factors always are going to trump the general population level, first line treatment. So that was a great question. All right, did you guys? I saw a hand over here for a minute.
Because when we answered question 4, we said naltrexone because then it was like after question 4, it said he follows up and says that he has trouble sleeping.
Mhm.
So it was like it wanted us to answer not the final one, and then he had trouble sleeping, and then we changed it to naltrexone.
Say that again? Go ahead, say it
Do
again.
you know what I'm saying?
Say it again so I can follow you. What?
Yeah, but you can't. Oh, didn't it? Yeah. So
Well, he started drinking because of insomnia, so that's a huge. If it was just another side effect thrown in there, you may stick with the first line agent if it's just we're just talking side effects in general. But he actually relapsed because of insomnia and anxiety.
So question 4 and 5 would both be the disulfiram.
Read question 4 out loud for me.
It just said your long-term medication management, and then it said follow-up 3 months later. He's having trouble falling asleep. Change your medication.
Yeah. So this is case study versus. Excuse me. This is case study versus like real life, right? The case study is designed to walk you through a series of events because I know that you're going to go first line first. First line doesn't work in this case. In a real life setting, what you'd want to be doing if somebody came up to you and said, "What are we going to do here?" You're going to say, "Well, these are the first lines, question 4, but we're going with question 5 because he has insomnia and we don't want him to return to drinking. He has a supportive wife." So case studies set up just to walk you through them. Right? Good question though. You guys see that? You see how that's set up? Question 4 and 5 are only meant to guide you through it. That's it. All right, so you guys are talking about, so there must be good questions for me.
So, because he has a supportive wife, he was able to abstain from drinking. Would you try to treat the insomnia because that's what initiated his relapse?
There's an obvious answer, right?
Even like Lunesta, which like for people with trouble falling asleep.
Right, so it would be perfectly appropriate to target the insomnia instead of the alcohol dependence. Just like it would be perfectly acceptable to target the blood pressure versus the case we had last week, right? There are different approaches. You guys will have a sleep disorders lecture depending on when the exam is coming up with Devin Sherwood where you talk about the Z drugs, you talk about the benzos. Now this person does have some benzo issues.
Trazodone.
You could go with a non-addictive sedative such as trazodone or any number of antihistamines, right? Any number of antihistamines. An antidepressant with sedating effects. I mean, we can go on and on about what you might give, but it would be perfectly acceptable to target the insomnia and then just go psychosocial for, or non-pharm, I'll call it, non-pharm for the alcohol dependence. Is that what you're asking? Yeah, definitely. Good question. All right, what else? I saw a lot of people chat, so there had to be more questions than that.
What does oral absorption adequate mean?
It's poor. You don't get much. You don't get much thiamine.
It says for Wernicke-Korsakoff syndrome, little evidence is available regarding optimal dose frequency, duration, and route in which patients.
Check. True. Yeah, we're gonna talk when we get to thiamine. It's like one of my dream studies. People have been recommending thiamine ever since I can remember. It's a water-soluble vitamin, doesn't have any side effects, prevents a lot of neurological sequelae, right? Well, a couple years ago I was writing something or another, and I was trying to make thiamine recommendations, and I discovered that there are no data to support thiamine recommendations. So then what I did is I went to all of the expert guidelines, and of course they both say, the British Association of Psychopharm and the APA guidelines, the American Psychiatric Association, they both say what I had just found out, which is the data is very little, and then what you end up with is the British go very aggressive, we go very conservative, but at the end of the day, nobody really knows. So my dream study is to find out, to actually assess it, but I'm convinced there's got to be a reason that nobody's studied it, and I don't know what it is. One of these days when I have, some free time, I'm going to try to figure out what's going on with this thiamine issue, because it's one of those really obvious things that you will see every day, but everyone does it just because that's what the people before them did, right? You're going to see it a lot. Didn't we just talk about another example like that? Where people are just doing it?
Methadone.
What? Yeah, methadone. Why is methadone, thank you, why is methadone the methadone that's used for opioid substitution? Mike asked a very good question today. He said, well, why not use a cleaner opioid agonist? And I'm not talking about buprenorphine, which is a completely different beast. Why not use another opioid agonist? Because methadone is really, really dirty, kinetically and dynamically. Right? Are we doing it just because that's what we were given? I bet you there's more to it, like the laws. We'd have to uproot all the laws and start over, and that's probably, a headache. But there are a lot of situations like that where you are just going on faith because that's what was done before you. And to me, thiamine is the ultimate example of that because it is water-soluble B vitamin that can prevent a lot of problems. But we don't have any idea how to use it. Yeah? Good? That went pretty good for not having a lecture. I feel good. I feel, I can feel the neurons firing. I feel like a preacher or something. All right, so we'll to be determined, to be continued on the scheduling. We need to talk to Sherwood, and I will put out a black book email, lock it down. But we'll try to avoid having 3 exams in 3 days.
I am going to post this for people in case class gets canceled tomorrow, so they will at least have it.
Actually, I should say don't come tomorrow.
Yeah. It's fine.
Thank you.